drugs for obesity, people will become dependent on drugs and they will not change their lifestyle.
Very important point, but let me be a little bit mean. If you have a patient who has high blood pressure and you give a drug which reduces blood pressure and the blood pressure is well controlled, and if you stop the drug, what happens? Blood pressure goes up. What do we say? We say you need to take the drug. In obesity, it's totally different because we think that should be managed. I gave a lecture recently, is obesity an infection? Because we give it like an antibiotic and then the problem is solved. I have learned so much in the last couple of years, and in particular in the last 2 years, because we have been involved in most of those trials as well. You might have heard the SELECT trial with semaglutide, people without diabetes, people with a heart attack and a stroke, a 20% reduction in mortality with a side effect of weight loss. So I think these drugs help us to understand better the obesity disease. I have prescribed semaglutide to some patients, and usually you go up in a very stepwise fashion with a very low dose and then you increase. And to me, I was really very much touched when I had patients to call me in that up titration phase, and they were still on 0.25, the lowest dose. After 2 weeks, they called me and they said, "Doctor, what did you prescribe to me? I have no hunger anymore. I'm totally free in my mind because my brain was always telling me, listen, this is great, you should eat it." But the other part said, no, you can't eat it. So they were caught the whole day to be considering food or not food, to food or not food. And all of a sudden, all this stimulation is gone. And that is very remarkable to me because I could show you a couple of slides about the brain metabolism of GIP, GLP-1 and so on. And it seems to be that in some people there is a disease, there is a loss of or a decreased function of these GLP-1 hormones to control appetite. And as the people grew up like that, they never experienced it in a different way. We have now so many people in different types of trials where I would say not everyone responds, but 90% of the people respond. And we are just at the beginning to understand, because we have people who had been treated with semaglutide and have lost 3 to 4 kilograms. We are now doing a study in non-diabetics cardiovascular risk patient as a cardiovascular outcome trial with tirzepatide. They have lost 17 kilos in a year. So number one is there seems to be a susceptibility, and there seems to be indeed abnormality which is corrected by the supply of GLP-1. We don't understand why. We now face the problem, as you just said, how long do we treat? Because the studies went on at the most, like the SELECT trial, for 5 years. Do we have to continuously treat them? I would say, first of all, we are so grateful to have drugs which allow us to help the patients for a double-digit weight loss. And I can tell you, I have many patients who started to exercise after they lost 3 to 5 kilograms because the knees didn't hurt. And they had fun in exercising. So that will support their better lifestyle. And I have people who told me, hey, this is strange. I start eating the healthier food and I love it. Because beforehand, they ate whatever they got. Now they prefer the healthier food without any co-education. That also seems to be a little bit managed by the brain. But as we all have to say that there is a lot of research necessary in the future for us to understand how we can help these people. Maybe it's intermittent therapy. So this is eminence-based. I have patients who stopped it now after they lost 10 to 15 kilograms. They started to exercise. They had understood that they can eat smaller proportions of food and they survive. But still, they say, the bad guy, the devil, comes out and says, hey, there's food over there, let's go. No, you can't. And then that starts again. We will have to see. I know from the old studies with sibutramine and with rimonabant, in particular sibutramine, they had an interval study, so they treated the people only every other month, so halving the costs. And at the end of the year, the outcome was the same in terms of weight reduction. But I tell you, we need to learn a lot, because there are super responders and there are non-responders. We need to know why. And we also need to learn how to manage people who had lost the weight to maintain that weight. And we also need to make clear to our patients that weight loss needs to target realistic aims. Because if you talk to a patient with a body mass index, or let's say a weight of 120, they want to lose 40 kilograms. And they think a loss of 20 kilograms is no success. And the most important thing I learned in the last years, it's not about losing the weight, it's maintaining the lost weight. And this is where we usually leave the patients alone. Your question. Did that answer your question? Yeah. Okay.
I am so honored from you to be in this hall and to hear from you. Many thanks for your presentation. My question starts from your last slide, from take-home message. You said type 2 diabetes is a malignant disease. That means pre-diabetes is like pre-cancerous, or even more worse, because complication can happen. Why there is no, or maybe there is, I don't know, concentration more and more in pharmaceutical companies to tackle pre-diabetes? We have a lot of studies that said metformin and recently sodium glucose transporter inhibitors can help. So I think we just concentrate on pre-diabetes to prevent type 2 diabetes. This is maybe more helpful and more in future reduce the risk of cardiometabolic disease. Thank you.
You're completely all right. We even have data for pioglitazone. We have for even orlistat data to prevent diabetes. We have data for SGLT2 inhibitors and so on. One of the reasons why the healthcare providers are not willing to pay is costs. And the other thing, honestly, is also that at the very moment we do not have one single study which showed that if you treat the pre-diabetic patient, you have less cardiovascular events. Because this is not, I'm not blaming the researchers not to do the right thing, because at that time the most important thing was to prevent the development of an increased HbA1c, as we call it, diabetes. But now the new knowledge is that you have the same risk factors except for the increase in HbA1c. And you are not taking these guys for serious. Isn't that ridiculous? But it will take a lot of time because it's extremely difficult. I was involved even 20 years ago in setting up a study in pre-diabetic subjects. We got $10 million at that time from troclitazone. You might recall that's a precursor of pioglitazone, because they wanted us to do a study to look at, if we treat people with pre-diabetes, we will end up having less events. And I was in the planning committee, and we calculated how many cases we would need and what would be the high-risk subject to produce a lot of events in order to shorten the time we need. And at the very end, we never did the study because we would have had to have funding for 10 years. We would have had to have a high-risk population, but we at that time didn't know. Because if you have a high-risk population, you are not allowed to have them not treated for hypertension, not treated for dyslipidemia. So they all would have had to have the best treatment, and then it's very tough in a short period of time to really prove a major benefit. And that was the reason why we never did the study. And I'm afraid, honestly, we will never get the study. There might be in the future, as I just mentioned, the semaglutide trial, the SELECT trial, which was published in the New England Journal in December last year. 17,500 people in secondary prevention. There was this drastic drop, despite all the best treatment with statins and all the drugs. Now, in the SURMOUNT cardiovascular outcome trial, which is a placebo-controlled trial with high-risk patients, you have even primary preventive patients. But they have a high risk. They must have hypertension, dyslipidemia, and all that stuff. But if that study shows that also in the primary preventive group we have a reduction of events, that would be a sign of hope for us. And yeah, but the study is still running. We just have 1 year.
Yes.
Yeah.
Thank you, doctor. And for the sake of time, sorry for the interruption, but we have a long schedule today. So if there are any more questions, you can ask the doctor aside, okay, if possible. And
شكرا جزيلا على حضوركم. احنا بس عندنا البريك بتاع الغداء والصلاة، واستاذنكم نرجع 2 بالظبط عشان في ناس مستنيه في امريكا وايطاليا اونلاين، فاستاذنكم بس نرجع المحاضرة الساعة 2 بالظبط. وشكرا جزيلا. شكرا. Thank you, Dr. Stephan. Thank you.
Thank you.